Hi, fellow PAs and pre-PAs. Rob Lucas here. I was thinking of educating you all about retraction. So, as a PA in surgery, a lot of time is spent retracting, simply holding things out of the way for the surgeon. And there are a lot of retractors. We call it holding hooks. When you do a case, someone says, "How'd it go?" You say, "I was holding hooks for 3 hours." That's often the case because it looks like Captain Hook. This is called a deaver. I think most of these things, they are either named for what they look like, what they do, or I guess who invented the things. These are called Army Navies. We just call these two-prong hooks, but usually might say it's a 4 millimeter hook or you get a 12 millimeter hook. So it's two very pointy hooks. And in plastic surgery, you might be wondering, hooks, that sounds bad. It's like needles. It's actually less traumatic to the tissue because on a cellular level, hooks going in the tissue actually encounter very little tissue. It's just the point of the hook is really the only thing exerting much force on the tissue. Whereas a retractor that's got a ribbon blade to it, like that, the entire surface of it is being pulled. And you could pull it and actually whiten it like white knuckles. That's reducing blood flow during the procedure, and ultimately it's part of the trauma of surgery. And in plastics, we do atraumatic technique. It can't be atraumatic, the prefix a meaning without. This probably should be called a hypotraumatic technique or a reduced traumatic technique. So these are two various deavers, even wider, but there's times when you have to use them. So we tend to, in plastics, go for pointier hook type things, and then there's fairly pointy retractors that we'll call this a rake or a wide rake. So there's little points on this business here, and that's what's interacting with the patient. So it's less trauma in a sense than a wider ribbon. There's a Richardson retractor, which I guess is named after Richardson, and this is a 4-prong rake. So if you ask for a 4-prong rake, that's what you get in this office. A lot of offices also, and a lot of surgery centers have their own nicknames for things. Like this is a Robbie Bobby forceps. That'd be the forceps that I prefer. The thing about retracting too in surgery, there's a right way. You're not going to last long if you are given a retractor in this position where your arm's like a big outrigger and you're trying to hold it using your deltoids, which is a relatively small muscle compared to things like pecs and lats, and you're holding it. The doctor sets you up. What he does is he puts it in, he puts it where he wants it, and then he either pauses or just gives it a shake. And the shake means take it, and then you take it from him. Now, if you're holding it for him or her and they want to move it, they put their hand over yours. That means they just want to move it and set you up in a different place and leave you in that new place. If they grab it and take it from you, you surrender it. And then they do what they have to do. If they get to a point where they want you to take it, they give it another shake. It's good if your hand is in ready position, and as soon as they shake it, you've got it. Once you've got it, you got to try to do what you can to be comfortable. Sometimes it means using two hands to hold it. So if you have to be like this, another hand underneath, and that hand underneath will also be resting on the ribs. When you can, they set you up with a rake. If your arm's by your side, a big deaver, and you're pulling up maybe 10 pounds of pressure on the deaver, your arm by your side will be stronger than your arm out to the side. There's times too when the patient's in a position that if the patient's, let's say, shoulder was there and you're holding this here, you may be able to rest at least 1 or 2 pounds of pressure on your elbow. It'll also make you more stable. Stability, not shaking for the surgeon. And as your muscles begin to fail, you begin to quiver a little bit. So if you can get a little bit of a rest, but you must always be aware of what's underneath that drape. Is it their Adam's apple? Is it their head or their eye? So you have to be aware of what's on the other side of the drape when you rest down on the drape or on anything. Obviously, resting on a soft part of the patient is as good as resting on a shoulder or the hip bone, something like that, where you have a little bit of purchase and there's less chance to do any harm. So there's lots of nuances to doing retraction for surgeons. There's also what we call distraction for the original incision. So you put your hands on the skin and you separate them. Makes the skin taut. It makes the markings very clear that he or she wants to cut on. And when they do cut, they get a nice clean cut. They don't get a ragged edged cut. From there, you usually go to hooks, and the surgeon gets to deeper layers. And from there, they'll graduate to the bigger ribbon things because they're, let's say, under the muscle of the chest doing the breast augmentation. Another thing is, if you've got two retractors, if they set you up with two to hold, if you could somehow connect these two, like if you can be like this, it would generally be retracting this way or something. Let's say I'm retracting from the side. He or she's got me lifting up two. I'll try to get my hands leaned into each other because that forming a link makes you stronger. It's easier to maintain. You might put one hand under the other and then later on switch it like that. Well, duty calls. Good to see you.